Okay, thank you very much. Primary deep vein incompetence is not as frequent as secondary. It was described first in 1972 by Albert from Sweden. Thank you to Bo who remind me that, but it does exist. The first valve repair was performed by Bob Kistner in Hawaii 44 years ago. That is the initial presentation. What is the goal of deep venous reconstructive surgery for primary reflux? Of course, is to correct the deep primary valve incompetence at subinguinal level that is responsible of extended deep venous reflux. We will see that only axial reflux matters. But it must be kept in mind that deep venous reflux is frequently combined with superficial and perforated reflux. Consequently, at least superficial reflux has to be corrected in order to reduce the ambulatory venous pressure, but also, besides primary deep obstruction, is sometimes associated with deep venous reflux, so it must be corrected first. That was very clear. That is a normal valve, the two-free border came in contact, and in a primary valve incompetence, the valve is not destroyed, but the two-free border does not come in contact. What is the technique for treating primary deep venous reflux? You can separate them in two groups, with phlebotomy and without phlebotomy. With phlebotomy, you have internal valvuloplasty, which is the most recommended technique, and in few patient valve transfer, transposition, or transplantation. The first internal valvuloplasty was described by Kistner. He performed a longitudinal phlebotomy to correct, and to repair the valve. After that, Raju suggested a transverse venotomy to repair the valve. I tried, but I was not happy with the one. But the best technique, in my opinion, is the internal valvuloplasty according to Sotiori technique, which combine transverse and longitudinal sections, so you have really a bird view on the valve and you can repair it easily, as you can see on this scheme. So you make the incision, and when you can see the valve here that are redundant, and after that you start to correct at one commissure, and after that to the other one, and when it's finished you can see that the two free border of the valve are in contact, as you can see here. Tripathi later described another technique which had, it was a trapdoor technique. I have tried it. I found no advantage on the Sotiori technique. Sometimes, okay, you cannot repair the valve for different reasons. I mean primary valve incompetency, so you can perform a transposition using the profunda femoral vein or the great saphenous vein, and that is on the profunda. Of course, you need to have a competent valve at the termination of the profunda or the great saphenous vein to make a transposition, which is not as frequent. And the last one is a transplantation. We use axillary vein. You can see here, it can be made above or below the knee. Other techniques are without phlebotomy. You have wrapping or bending, transmural valvuloplasty, and transcommissural valvuloplasty. Bending, the most famous was VENOUS, but it was used only by one surgeon, Lynn from Australia. And external valvuloplasty was again described first by Kistner, and later Raju and Niglan described the transcommissural valvuloplasty. I've performed some of them in complement of internal valvuloplasty at the popliteal level. And as mentioned before, artificial valve through vascular access would be the ideal situation. That is the last generation valve, BVV2. That is a side view of the valve. And you can see it was a photograph of a ship jugular vein. Unfortunately, Kavnik started 30 years ago with the artificial valve, and until now, it was not successful. What was the outcome of the different one? You know, briefly, I will show the valvuloplasty result. You can see that the number is not very important, and we assess both the competency of the valve, the clinical result, and ambulatory venous pressure and venous refill time, in order to be sure that there was a correlation between clinical data and hemodynamic results. That is the first series. It was published first by Masuda and Kirshner in '94, and we go ahead, Raju, Tripathi again, and the last one was by Letola in 2008. At 5 years follow-up, to resume, valvuloplasty is credited with 70% of good clinical results, hemodynamic improvement, valve competence. In all series, a good correlation does exist between the three elements, and in most series, when people perform internal valvuloplasty and external valvuloplasty, the outcome was better with internal. That is a result of the banding. Again, very few patients, you know, that was the report in the literature. And of course, I have to report the Vedensky spiral, which will be the topic of the next speaker. And there was a series, but we don't have that, we don't know exactly if patient had ulcer or not. So cuffing results are difficult to assess because they are various in terms of technique of material or device, use or not of perioperative angioscopy, and sometimes the outcome is not fully documented. Indication. Indication for deep venous reconstructive surgery relies on clinical, hemodynamic, and imaging criteria. Clinical criterion, of course, is symptomatic patient, C4B and C6, only this patient. And the most important is the hemodynamic criterion, axial reflux, uninterrupted retrograde venous flow from the groin to the calf. We never perform valvuloplasty in segmental reflux, that is very clear. And that is, of course, for example, a primary, you can see the reflux is primary. And when you look carefully at the phlebogram, etiology is crucial. You want to know if it's a primary or a secondary incompetence. And in this case, I am sure that I can repair this valve. It's obvious, you know. Here it is. I can repair this valve. And sometimes, when you cannot repair, you must know if the transposition is feasible. In this case, you know, the deep femoral vein is competent who can make a transposition of the superficial on the deep. In conclusion, deep venous surgery for reflux in primary etiology is effective in selected cases, providing grade 1C recommendation. But I agree with the previous speaker. You know, if you have a combination of superficial reflux, you must treat it first, and you have to look if there is no obstruction. And if you find an obstruction, primary obstruction, I mean, you have to treat it first. And of course, deep venous surgery for reflux is not easy to perform. It's not often indicated and has to be performed in